Hello everyone, welcome to Psychological First Aid and Mental Health Awareness. So this is a workshop to help support a colleague who's in distress. I'm Wendy Hartridge, I'm a consultant clinical psychologist in the staff wellbeing team. This is a workshop that we originally devised for the anaesthetists ahead of the coffee club. So anybody who is co-facilitating that or wants to know a little bit more about supporting colleagues, this is for you. It should take around 45 minutes to an hour for this workshop. So today we're going to define what mental health first aid is and isn't, to define what psychological first aid is and isn't, and to explore the core helping actions to support someone in distress. And by the end of today's session, you should feel reasonably confident in delivering support to a distressed colleague, and also know where and how to signpost someone for further support here at NUH. So it's probably useful to define what mental health first aid is. It's help offered to a person developing a mental health issue, who may be experiencing a worsening of an existing mental health issue, or is in mental health crisis. And the support that we offer under mental health first aid is given until appropriate professional support arrives. So exactly the same as physical first aid. We might support somebody, we might help stem the flow of blood or patch them up until the professionals arrive. It's the same with mental health first aid. So mental health first aid is a particular programme devised by Mental Health First Aid England, and they have 4 main aims and 2 subsidiary aims. So the first is to preserve life where a person might be at risk of harm to themselves or other people. Second is to provide help to prevent a mental health issue from becoming more serious. The third is to promote recovery of good mental health. And the fourth is to provide comfort to a person with a mental health issue. So those subsidiary aims are to raise awareness of mental health issues in the community and reduce stigma and discrimination around mental health. So mental health first aid arose out of members of the public supporting people in mental health crisis, and a programme developed out of that so that people knew how to help. We often know how to help somebody physically, but that we still send people on physical first aid courses. So this was to raise the awareness of mental health issues and to help people, perhaps members of the public or colleagues at work, to support each other. So it's probably helpful to start with what mental health is before we decide whether we need to support somebody with mental health first aid. So the World Health Organization have a very broad definition of mental health, and they say it's the mental health is a state of well-being in which the individual realizes their own potential, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. And mental health means different things to different people, but by and large, this definition encapsulates the idea that poor mental health equates to a decrease in function and ability to engage sufficiently with the world. And because it's so broad, the definition means that most of us will fall into the category of having poor mental health at some point, just as we do with physical health, because we don't consistently have the bandwidth to achieve all of this all of the time, and are subject to outside influences that impact on our ability to deal with the daily rigours of life from time to time. It's also important to remember that just as anybody is susceptible to mental health difficulties, the people who do have diagnosable mental health conditions function absolutely fine for most of the time. Everyone's experience is different. So how big is our mental health problem in the UK? Well, if we look at this, these are GP patient figures from last year. So in 2022, you can see there that Nottingham and Nottinghamshire had a 13.7% incident rate of mental health difficulties. But that's only those people presenting to their GP. The real number is probably somewhat higher, of people who would say, particularly if we think about the World Health Organization definition, that they're experiencing poor mental health. So why might we need mental health first aid? Well, mental health issues are common, as we've already found out. And if we include things like the misuse of drugs and alcohol, then 1 in 4 people experience some kind of mental health difficulty every year. Therefore, it's highly likely that each of us will experience poor mental health or be intimately close with someone who does experience poor mental health during our lifetime. There still exists a huge amount of discrimination around mental health issues, which leads people to feel ashamed and to hide their mental health issues. The knock-on effect is that people may delay getting help or find that this compounds their difficulties. Those with mental health difficulties can find themselves excluded from employment, housing, social activities, and relationships. And myths around mental health can lead to people fearing getting involved or getting help, such as the belief that people with mental health issues are dangerous. Lack of investment in services has led to delays in the system, so that by the time someone seeks help and is accepted into a service, the problem may be long-term or entrenched. And of course, some mental health problems cloud our thinking and good decision-making. So in this situation, it can be crucial in terms of the person accessing appropriate support that they have somebody around them who's advocating for them or helping them with those decisions. People often worry about doing or saying the wrong thing, but it's always better to try and help than to leave someone in a state of distress. So I think this is really useful to conceptualize mental health. It's not an either or. We're not sick or well. If we think about that definition, as it's a wide umbrella and there's no absolutes in there. So this is a really good diagram to think about that. So while somebody might have a diagnosis of a mental health condition, they might be on a continuum of doing really, really well and have very positive mental health while still having a diagnosis, versus having the diagnosis and having very poor mental health and perhaps being in an inpatient facility. Equally so, people may not have a diagnosis of a mental health condition and still be functioning very poorly. And equally so, we can be well with no diagnosis. So it's useful to think about this as a very much a continuum, and that we're somewhere on that sliding scale and it moves about from time to time. So it's important to think about those factors which influence our mental health. So there's a number of protective factors there, such as having a positive experience of being parented, a high education level, a good social network, accessing physical activity, good nutrition, rest and reflection, and so on and so forth. Some of the risk factors that influence mental health, often making it poor, such as alcohol use, drugs, smoking, stress, trauma, poor parenting experience, poverty, unemployment, poor education, discrimination. And we know from research those things have a massive impact on our mental well-being. It's really useful to think about how we conceptualize mental health, and there's a broad church. So some people believe it's a disease, that there's an imbalance of neurotransmitters or hormones in the body, which leads to poor mental health, or there's some organic damage that has caused the situation. Others believe that it's environmental stress, either external or internal, that makes our mental health poor. I like to think it's probably a little bit of both. So it's nature and nurture. So if we think about what we call in psychology, rather than diagnose, we tend to formulate a narrative around somebody's experience of mental ill health. So, for example, somebody might experience critical parenting, which would lead to negative internal thinking about ourselves. And this might be triggered again by difficult work or a difficult environment, which might lead to low mood and depression. Or, for example, somebody experiences a serious road traffic accident, which leads to worries about it happening again. Feelings linking back to the events, so those kind of traumatic experiences, leading to fear of travelling in a car, and eventual agoraphobia, withdrawal from society, and mental health difficulties. So there's no firm evidence for either process. As I say, it's probably a bit of both. What I do know is that there's a predominance of trauma and abuse and factors linked to disadvantage in mental health populations, similarly with prison populations. And we know from the efficacy of medical interventions and therapy, they're pretty poor, slightly better for talking therapy on the whole. But if we use that bit of knowledge to help us conceptualize mental health, so we know that talking therapy is helpful, some drug therapy is helpful. Again, both impact whichever conceptual model you have. And if we think about the factors that impact mental health that we talked about in the previous slide, then we might think about what might cause that. We know from epigenetic studies that mental health can be hugely impacted both by the genome as well as the environment. So this is another way of diving a little bit deeper into the conceptualization of mental health. Really old-fashioned way of looking at things. This is not the modern way of doing it, but I think it helps us on a kind of basic level to understand everything that sits under that umbrella of mental health. It's really important to remember that comorbidity is really common in all of those conditions. So let's think about neurosis to start with. That refers to those conditions such as anxiety, depression, OCD, where the person is aware that they're experiencing difficulties, but they remain in touch with reality. Psychosis, on the other hand, refers to those conditions such as schizophrenia, where the person may lose contact with reality, either by experiencing stimuli that are not apparent to other people, such as hallucinations, or they may have beliefs that are unlikely to be true. Again, we need to understand that even those beliefs that may appear to be untrue might be part of a belief system or a faith or whatever that is important to the person, and that this is not about a psychotic belief, but just an unusual belief. Another part of mental health is something called personality disorder. It's another controversial label, and it refers to a cluster of personality traits and ways of relating to the world and other people that are problematic for the individual and those around them. It's often rooted in childhood trauma and is probably more accurately described as complex PTSD, but again, a lot of debate around that. Another section that comes under that umbrella of mental health is neurodiversity. It refers to those conditions that are thought to be organic in nature and affect functioning, such as autistic spectrum disorder, ADHD, dyslexia, etc. Again, there's lots of myths and misunderstanding about neurodiversity because as a Western culture, we place a high value on traditional academic achievement as being somehow superior, whereas there's lots of literature that in a society, a sort of tribal society, which values diversity, skills of neurodiverse individuals are important to the collective survival of the community. And the final element that sits under this umbrella of mental health is learning disability, dementia, acquired head injury, all those kind of cognitive functioning disorders. And they can interact with other mental and physical health difficulties too. So common treatments for mental health difficulties fall into two broad categories: pharmacological and psychological. So under our pharmacological tab, we've got antipsychotics, antidepressants, stimulants, anxiolytics, and mood stabilizers. Under the psychological, that can be quite extensive. There's a number of therapies that people can have access to. The most common one is CBT, cognitive behavior therapy. That has now developed into what's called a third wave CBT therapies. So often they're compassion-based, or they have a mindful element to them, because we know that those can help increase the efficacy of CBT. Then there's more traditional psychotherapy, such as you find more kind of Freudian work, which is intense psychotherapy with a trained analyst for years on end, where people associate in kind of, while the therapist analyzes what they're kind of coming up with in the session. Counselling tends to be sort of person-centred, where the counsellor will reflect back to the person as they find their own answers to whatever problem that they've come with. And again, used more in learning difficulties and sort of inpatient facilities, more kind of behavioural interventions, where there might be positive reinforcement for a particular type of behaviour and discouragement for more negative behaviours, in the hope that the behaviour changes. So in relation to what the needs of somebody in mental health crisis might need from mental health first aiders, there's a sort of 5-point action plan with its own little acronym called ALGE. And the idea is that we approach, assess and assist with any crisis. So that might be where there's any risk of harm. We notice that and we approach and assess the risk for that. The largest part of our intervention is the L, which is about listening to somebody non-judgmentally. So tell me what's going on for you, and we listen. Then we give support and information. So if you have any knowledge about mental health difficulties or any support organisations, we might give them some support around that. Encourage somebody to seek professional help, help them to get that help, and encourage lots of self-help. So asking them who is around to support you, who helps you, and encourage them to use those supports. If we're going to support people in a mental health first aid capacity, it's really important that we look after ourselves. This can be really hard, very draining work, because we listen to people who are quite distressed and need high levels of support. So it's important that once we've done some of that, that we have a plan for ourselves and our own self-care in the background that we can activate whenever we need it. And I've also put on there, it's really important that we're culturally sensitive. So be mindful that mental health has a wide range of cultural beliefs around it. But also that things that, if we think back to those things that impact on mental health, I mean sort of culturally in the widest sense of the word. So environment, disadvantage, poverty, all of those kind of things are part of what I would consider to be cultural impacts, and we need to be sensitive to that. So gender, sexuality, race, all of those things become involved in our mental well-being. So being sensitive to that and asking with respect what people's belief systems are, where they are in terms of their understanding of mental health issues, and being open to listening to different viewpoints about that. So it's really important that we talk about suicidality in this, bearing in mind that mental health first aid grew out of the need to help somebody in crisis, so people who may well be feeling suicidal. People often worry about talking to somebody or asking the question about, do you feel suicidal? Because we unfortunately worry about that question might encourage the person to act on their feelings. In reality, research shows that speaking openly about suicide decreases the likelihood of a person acting on their feelings. So we recommend asking directly about it. The crisis and the emotional distress will already have triggered the thought if it's there at all. So your openness and concern in asking somebody will help them feel less isolated and can actually act as a deterrent. So what should we say? We need to be clear and direct and ask calmly about thoughts of suicide. So again, that direct question, are you thinking of suicide? We might infer that somebody might have those thoughts. So I'm hearing what you're saying. It sounds like you've got a lot going on at the moment. People who feel this way may have thoughts of suicide. Are you having thoughts of suicide? And then let them answer. So listening really carefully, going back to that ALGE acronym, listen non-judgmentally. If you don't feel that you've got an answer to the question, ask again. If they say yes, then ask a little bit more. Again, don't worry too much about this, because once somebody says yes, then we're going to get them some help. But we might ask a little bit more about the intensity. How long have you been feeling this way? We might ask if they've got a plan. Have you thought about how you do it? When do you plan to do it? Because this helps us understand their level of risk. Do you think you'll act on it? Have you done so in the past? Are you on drugs or alcohol? Because that increases the risk. But we also want to hear about social and protective factors. So what and who helps keep you safe? If somebody asks you to keep it a secret, never agree to do that. If somebody discloses that they are at risk of suicide, then we have to act. It's a safeguarding issue, and we have a right to protect life. It's just some common myths about suicide that might be useful for you. So the idea that once a person is considering suicide, there's nothing we can do. Actually, suicide crises are often time limited and are based on diminished problem solving. So actually, once somebody decides or thinks about suicide, often other opportunities or other solutions to the problem get pushed to the side. So we need to open up that again, that option, that there are other ways of dealing with the problem. Another myth is that suicide happens without warning. Sometimes it does, but not always and not necessarily. Many people do contact services in the months leading up to a suicide attempt or indicate their feelings to someone. Another myth is that suicidal people want to die. What we know is that often they want their emotional or physical pain to go away, but not necessarily stop living. Another myth is that once people improve, the risk disappears. Actually, sometimes that can work in the opposite direction. So sometimes if somebody's acutely depressed, their motivation disappears, but once that motivation comes back, the risk can increase. The thought that suicide occurs more in certain classes of people or certain cultures, that's not true. All classes and cultures are represented equally. The idea that suicidal people are loners. Many people with suicidal thoughts are more likely to withdraw into themselves leading up to this. However, people who like their own company are not suicidal. Again, another myth, no one has the right to stop a person who wants to take their life. The difficulty with that is often suicidal feelings are temporary, and when people have the right support, that suicidal thought might go away. So actually what we want to do is preserve life. So that kind of covers mental health first aid. Let's talk a little bit now about psychological first aid. I think it's slightly poorly named. It can be quite a deceiving title. So psychological first aid suggests exactly what we've been talking about. It's to do with mental health. In fact, the term psychological first aid is only used to distinguish it from physical first aid. And it could just as easily be termed emotional first aid. So just as all of us can fall over on the pavement and need physical first aid, we all have emotions and we all have reactions to what's happening around us. So if we are unfortunate enough to have been involved in something, we might well need emotional or psychological first aid. There are certain things that cause all of us to feel overwhelmed, upset, distressed, and in need of some help. Just if few ideas about what psychological first aid is not. It's not something that everybody affected by a distressing event will need. So not everybody is affected by the same event in the same way. It's not professional counselling or therapy. It's not something that only mental health professionals can do. It's not psychological debriefing. It's not analysis of a person or trying to figure out what's caused or affected them. And it's not about pressurising a person to talk about their feelings. It's just emotional support in the moment for a person. So why psychological first aid? So there's lots of really good evidence from the World Health Organization, world crises, disasters, terrorist attacks, COVID, crime studies, the military, that tells us that people are more likely to cope and recover from a stressful or traumatic or unexpected event if these things are in place, that they feel safe, connected to other people, calm and hopeful, that they have access to social, physical and emotional support, and that they feel able to help themselves so that they have agency over their destiny, both as individuals and as communities. So there are 7 core helping actions in psychological first aid. The first one that we need to attend to, it's the primary one, is care for immediate needs. So if somebody is in an unsafe situation or they're incredibly distressed and unable to kind of take in what's happening, we need to make sure that they're safe and looked after. So if there are any physical issues that need dealing with, that we attend to those first. So anything immediate, what do you need to do right there, right now in the moment? Once you've taken care of any immediate needs, then we need to protect from further involvement or any other threats. So for example, if we think about an AVH in the department, is somebody physically hurt? Do they need any medical attention? That's care for their immediate needs. Then let's get them away from the situation, from that shouty person or whatever it is that's happened. Make sure that they're in a safe and secure place and, a comfy office or wherever it happens to be, so that they're out of the way of any further danger or trouble. The next one is comfort and console somebody. So just taking care of those immediate emotional needs. Yeah. So allowing somebody to cry or to calm themselves down. Then we need to support practical tasks. So what do you need? So again, we're giving people agency over their destiny. What is it you need from me? So a situation might be somebody's phone's being stolen. Now that would send anybody into a panic. So do you need access to a phone? Do you need me to call somebody for you? Have you got a number that we need to let somebody know if somebody needs to contact somebody for a lift or to pick up the kids or to let somebody know or to let their mobile phone provider know? So those kind of practical tasks in the moment. Then we might provide a little bit of information on coping. So we might help somebody what normally helps with coping. What do you normally do? If they don't have a lot of ideas about how they normally cope, what would be helpful to them in terms of coping with this situation, then we might offer some. We're going to connect with social support. So that's what we're doing by offering psychological first aid. We're initially contacting and connecting with somebody. But we're also going to get them involved in their own social network. So who do you normally go to for support? Can we contact them? And then we might offer them some education around normal responses. So it's not unusual to feel distressed. We'll get you some help and signposting on to appropriate services. Again, just like mental health first aid, if we're going to do this and offer this to people, we need to take care of ourselves. And that's in the centre of the circle so that we remember to do that. So just thinking about how we might help somebody to feel calm when they're really traumatised or really upset and distressed. So keeping a calm voice, keeping eye contact, reminding somebody that we're here to help, reminding them that they are safe only if it's true. If it's not true, and we don't say that. We might ask somebody to focus on their breathing. We might help them to breathe. So sometimes it helps to tap fingers or to tap what we call a little butterfly hug. So crossing our hands across our chest and just tapping, just to help the brain calm. Helping somebody to do something that we call grounding. So what can you see? What can you hear? What can you taste and touch? So getting them that kind of sensory information to help them get back into their bodies. Often the difficulty that we have is we get into our own heads, and that's where the anxiety spirals out of control. If we can get somebody back in the body, then we can reduce their anxiety. In terms of comfort and consoling somebody, it's important that we approach people respectfully. May I? Is it okay if we go somewhere for a chat? Is there anything you need? It's important that we're calm and we take it slowly. Give people plenty of time for what they need. Some people might not want to speak about what's happened, so we might say to them, I'll sit here with you quietly until you feel able to carry on. We might make them a cup of tea. We won't pressure anybody to tell us what they've been through. So we might say, maybe now's not the time to talk, but when you're ready, I'm here. So remember, again, going back to mental health first aid, remember that active listening is the most important part. So we might say to somebody, you seem sad, you sound hurt. We can repeat back, paraphrasing what they've said. What I've heard is, or just using the last few words that they've said. If anybody's got teenagers at home, that's sometimes the best way to communicate with teenagers, is that we kind of let them know that we've heard, but don't engage in a kind of dispute with them. So again, allowing for silence, telling somebody that they're really interested in what they've said. Open questions. What's happening? What's showing up for you right now? And just remembering that listening is an action. It's something that we actively have to do. It's not something that we're passive recipients of. Some helpful do's and don'ts. We don't offer to do things for people. We ask them what would be helpful from us. We can't make promises to people. Can't demand that they tell us something or give them advice or belittle them or tell them they're lucky or it could be worse. What we want to do is encourage somebody with support. Some suggestions for providing support for practical tasks. It might be important that ahead of doing some psychological first aid that you learn or find out what's available for people. Where do we signpost people in this trust? And have details to hand of things that are available. So we can help with that in the staff wellbeing team, and there'll be a list of places that people can get support at the end of this. So again, thinking back to that poor person whose mobile phone's gone, imagine it was the whole handbag that went. It might be really difficult then to prioritise what they need to do. The car keys have gone, the mobile phone's gone, the wallet's gone. And people are unable often at that point to make any kind of sensible decisions because it's just sheer panic. And we know that when the amygdala has taken over, that our thinking part of the brain, our ability to plan and prioritise, disappears. And it's part of our evolutionary response to trauma. So helping somebody to work out what needs to happen, how to get somebody feeling less confused, less overwhelmed, less disorientated. Thinking about supporting people and information about how to cope. We might say things like, there will have been tough times in the past. What did you do to get you through it? What would be helpful now? If somebody doesn't have any usual strategies, then we might suggest some that we know about. So helping to relax, focus on things, or those grounding techniques. If somebody says that they've got very unhelpful coping mechanisms, like drinking lots of alcohol, we might suggest that that's not helpful, but give them an alternative. And then we might offer to provide some more professional support. So again, helping people to connect with the people that support them. We know from research that people who've had good social support after a crisis cope much better than those who feel that they weren't supported, and that includes the organisation. So if at NUH we are supporting staff when they've been through something difficult, they will respond much better and have a better recovery. So things that might be helpful is, as we've suggested, having access to a phone, lots of other methods of communication, encouragement to stay in touch with their social supports, and don't feel afraid to ask questions. Be quite nosy about somebody's social support so that we can point them in the right direction. Those who are TRIM trained in the department will know and be able to normalise distress responses. There's a particular phrase that we use in TRIM, which is the Tom Jones phrase. It's not unusual. So it doesn't matter how somebody is reacting. It's not unusual to be reacting in response to an event. So all of these things are completely normal after somebody's been in a distressed state or through a traumatic event or whatever it happens to be. So I said we'd talk about places where we can signpost people to support. This is a useful one because it refers to the Junior Doctors Support Network. Then we have the Staff Wellbeing NUH programme. Again, familiarise yourself with that. It's on our intranet and there's lots of different opportunities. There's mental health support, financial help, physical health support. Employee assistance programme is really helpful. It's a useful number to have on you. It has a little carry card that we can supply to you so you can give that to other people. And that's 24/7. It covers financial, legal, mental health support. So it's a real nice catch-all. So we've talked a little bit about mental health first aid and we've talked a little bit about psychological first aid. So when should we use which one and where do they overlap? So mental health first aid is about responding to a mental health crisis. Psychological first aid is responding to any distressed situation and it's the emotional support that we give somebody. So they have a huge overlap in terms of providing comfort, connection, education and self-care for people. In mental health first aid, we are looking to access professional support for somebody and we are looking at their risk and assessing that, which is slightly outside of psychological first aid because someone who's been through a distressing event may not need professional support. And the difference there is we're offering care, protection and support ourselves for that person. This applies to both things. It's really important because providing care in emergency situations is really stressful and can involve long hours and emotional involvement with very distressed people. We may feel stressed, upset, tired, overwhelmed, inadequate and frustrated. You may feel responsible for people's safety and care, and people may have many problems after a crisis event. You may feel inadequate or frustrated when you cannot help people with all of their problems. And what's really important about both psychological first aid and mental health first aid is we are not responsible for solving people's problems. We are doing what we can in the moment to help people help themselves. You may also hear stories of other people's pain and suffering. You may witness or even directly experience terrible things. And the crisis situation may have been very challenging and it can be really difficult to bear the distress and suffering of other people. And all of these will affect you and your fellow helpers. And a misconception is that NHS staff are able to cope with this. We can endure all of this adversity. But actually it's about how we restore ourselves that helps us face the challenges brought on by every day. And it's important to put our own oxygen masks on first before we help other people. So think about how you restore socially and at work. What enjoyable activities do you do? How do you find you time? How do you find activities that give you a sense of purpose or satisfaction? Consider your helpful and unhelpful strategies and be aware of alcohol intake or the impact on your ability to function on a day-to-day basis. After helping somebody with either mental health first aid or psychological first aid, take time to reflect on the experience for yourself and to take some rest. It might be helpful to talk to somebody else, a mentor or a supervisor, a colleague or someone you trust. Acknowledge that you were able to help in small ways. Reflect on what you did well and what didn't go so well, and what your limits are. Take time out and rest and relax before beginning your work and life duties again. Remember, the boundaries are very important. So try not to give out things like your personal mobile number or offer to see somebody on a repeated basis. If you find that somebody's leaning on you very heavily, get support with this. Encourage somebody to get more professional support. If we're going to encourage others to take time out for self-care, which is what we're going to do either with mental health first aid or with psychological first aid, we must model that ourselves. It can be very disingenuous if other people observe us not taking care of ourselves while we're telling other people to do it. Make sure that you always have your own trusted person to go to, somebody that you find comfortable, somebody you can offload to. Be mindful of your own biases and baggage. So things that are own, we all have a little blind side. So try and be aware of that and anything that we bring to the process. Don't struggle alone. Both mental health first aid and psychological first aid are designed to be crisis management techniques and not something that is an ongoing burden for people. That's for the professionals. And it's really important that we do leave the long-term work of supporting someone to the professionals. If somebody's unwilling to get professional help and say something like, yeah, but I like talking to you, we must again go back to drawing those boundaries and extricating ourselves from that situation. It's not healthy and it's not helpful. We're not in a position of being people's professional support. So again, just remember to take care of ourselves when providing psychological first aid and mental health first aid. It's a really nice conceptual model that talks about our systems in the brain. So our threat system gets operated whenever we need to do something, whenever our survival is threatened, or whenever we're anxious or worried about something. We get flooded with adrenaline and cortisol, and this tells the brain and the body to do something. So we tend to want to do things to either help or to make ourselves feel better. So it's a really good thing to do. It helps us motivate ourselves. We do lots of things as a result of that. However, if we keep doing that, we get into a situation of being busy. So we do more and more to help because feeling busy reinforces the threat systems in our brain to do more. And we can get into a rather unhealthy, unbalanced situation. And we always need to balance that out with something soothing. We know that dopamine and serotonin are really great reinforcers, and they're part of our blue drive system that respond to threat. But actually, we want lots of oxytocin to help soothe our brains and get the kind of balance right. So it's important that we have a good balance with our soothing system, that we do find ways to relax and promote that with other people. So should we use mental health first aid or psychological first aid? Well, there's a bit of me says, does it matter? Because the key points in both of those approaches are, if somebody is distressed in front of us, the key points are, don't be afraid to ask, are you okay? Can I help? We need to manage any immediate crisis. If somebody's at risk, then we do something immediate to help. We listen, and keep on listening. If that's the only thing we do, then listening is a great thing to do for somebody. We offer comfort and connection. Even just by listening, we offer those things. We're comforting somebody, we're connecting with them. If we can, we're going to signpost somebody because we're not going to offer to support them long-term ourselves. We might link them into something. We might give them a little bit of education. We might be able to signpost them in just the right way. Have you thought about doing this? And then in all cases, we get support ourselves. So it doesn't really matter to me whether we go down the mental health first aid route or the psychological first aid route, as long as we are listening to people and we're not afraid to ask, are you okay? Can I help? So again, there's lots of information on the staff wellbeing websites and on our Twitter feed. You can always email us in terms of the level of support that you can offer somebody and the types of support that you can signpost people to. These other ones that are external to the trust, if somebody's in a crisis, there are places to go. The Samaritans, there's a crisis line, GPs, and if you're really worried about somebody, A&E. So this is a super little free app that you can download onto your phone. I suppose of the two approaches, my personal one is psychological first aid because it's a little bit more all-encompassing. We're not suggesting that somebody has a mental health difficulty to offer psychological first aid. So you can download that onto your mobile and it goes through exactly the sort of things that you're going to ask somebody. So those little men that you can see, the little figures, you can click on that button and it'll say care and support or connection, and it'll give you some questions to ask that are relevant and some ideas to suggest for people. So it's a nice little thing you can pop on your phone. So if you're ever in a situation and you need a little bit of aid memoir, you can just click the button and you're off and running with some good questions for people and good ideas to support them. So thank you for coming today and listening to some ideas around supporting colleagues in distress. I hope it's been useful and I hope it's given you some ideas to think about if you see a member of staff or a colleague who is upset, that you feel confident to approach, listen, take them to one side, listen, calm and support. If you've got any questions, please do contact me via the staff wellbeing website, email address or website, or you can come to me directly. Thank you very much.